Looking for you. Yeah.
Okay. So is everybody at home or in the hospital?
I'm at home because we have a lockdown situation here. So most of us go for some time to the hospital and then we are back at our homes.
I see.
I'm at the hospital.
Okay. You are definitely, you have a daytime, now we have an evening time.
That's right.
So Dr. Mehul Acharya is in England. He's in Bristol.
Sir, we are live.
Yeah, okay.
Good evening, everyone. We welcome you all to Ortho TV online webinar. This is on emerging trends in osteoporosis management. Today, we have a variety of speakers, and I would hand over to our moderator, Dr. Ramesh Sen, to take over the proceedings.
Hello, good evening. Welcome to you in this webinar on one of the very important issue, that is osteoporosis. We all know that when we are talking about osteoporosis, we are looking at a situation where many causes with a different kind of a pathogenesis eventually end up in a poor quality of bone, which eventually leads to a fracture. As an orthopedic surgeon, fracture makes a big issue because most of these patients are likely to be women. And if you look at the percentage wise, in India, the number of osteoporotics is reasonably increasing to a very high number, and most of them are likely to be women. Very important in that perspective is, as we have also done a work at our place also, that they are not aware of the problem of their osteoporosis. And definitely, if they are not aware of the problem, we cannot think of getting out from this situation. Worldwide, a big volume, 9 million new osteoporotic fractures during the year 2000 globally. So it's likely to be a very, very big issue. And looking at the age profile also in 2010, 323 million people worldwide are aged over than 65 million. We have seen at our places also that we are getting these cases at 75, 80 years of the age, when most of these patients are coming to us with trochanteric fracture, neck femur fracture in most of these areas. Another problem we are getting is the risk of fracture does not end with one fracture. It goes for another fracture, then another fracture. And we know it out that the bone quality, due to all those factors, is already compromised. The bone density is reduced. As the age increases, our problem increases. And all those markers which are there, which we can assess the bone quality, we can assess the low BMD, all these are very important to know it out. Again, we have seen, I think Dr. Vadada, who is with us as a faculty, might remember that whether you do this evaluation, biochemical marker, it does correlate with the kind of the BMD readings. Now, as an orthopedic surgeon, looking at that quality of bone, which is already compromised, our fixation is also likely to be affected. Either we are getting these fractures as the bone is failing with the normal bone quality, which we call as insufficiency fracture, or they are resulting from a simple trauma, which we label as fragility fractures. One of the issues is diagnosis. Sometimes we come to see a patient with a painful hip with a simple avulsion of the greater trochanter, which in the days to come, as we keep on following, 2 weeks, 4 weeks, subsequently ends up in a bigger fracture, which we have not been able to diagnose. Other issue which we see is a kind of a pain and a small fracture. Now, if we are able to perceive that kind of a phenomena, we can go for a prophylactic nailing so that we don't end up in this situation. Another important issue is that these cases will need to be stabilized very early, because delay in the management also affects the mortality rate. We have got a different option of stabilizing the fractures which occur due to osteoporosis. We can go for the technique just like a minimally invasive technique, and with this way stabilizing these fractures, or we may put any of all those techniques into this area. We can augment this area with the cement and then can have a reasonably this thing, or if the bone quality is extremely poor, we can just stabilize and go for a replacement kind of an option. Or in the osteoporotic vertebrae, we might put cement, a so-called vertebroplasty can be done. And then there is a part to pharmacotherapy, which can be done and how it is to be done. Now, what is interesting is this is a survey of more than 3,000 orthopedic surgeons from 6 countries. What is found? That orthopedic surgeons, 90% do not routinely measure the bone density. 75% lack appropriate knowledge about osteoporosis. And in that event, we have got this today's seminar, that is emerging trend in osteoporosis management, courtesy Crosslands Life. And we have got a very good faculty with us for the seminar. We have got Girija to talk about the gynecological aspect. She's from Bharati Vidyapeeth Medical College, Pune. We have Dr. Shashank. He's from Bandu Fortis Hospital, Mulund, and Bethany Hospital, Thane. Then we have got two people, faculty, my old associates from PGI Chandigarh, Dr. Sanjay Vadada, who is the endocrinologist, professor of endocrinology. And we have got Dr. Mahesh, who is a professor in radiology and incidentally is a president of Indian Musculoskeletal Imaging Association also. Then we have got orthopedic surgeon, Dr. Shailesh here, who is working in Sancheti Spine and Neuroscience Unit, Pune. And then we have got friends from Germany, from Switzerland, Dr. Hans Pepe, who has done extensive work in these cases, and I was with him about 2 months back also in January also. Then we had seen that they have a lot of work to do in osteoporotic, and I definitely want to get a lot of information about their level of management. And then we have got other friend from UK who is regularly contributing to our education here in India from UK and by coming to this place. So welcome all the faculty and welcome all the participants. I have given the guideline of the course to go in for. We will first have some gynae issues which can be taken up as a case discussion also, as Dr. Girija will be doing it up. Then we'll talk about the steroid induced or a glucocorticoid induced osteoporosis, Dr. Shashank will like to say, and then how the basic endocrinology workup should be done. Dr. Sanjay Vadada will be talking about radiologically how it can be helpful to an orthopedic surgeon, the perspective of radiology. Professor Mahesh will be talking about, and then Shailesh will talk about how a spine surgeon, he looks at these osteoporotic vertebral fractures. And Professor Pepe has agreed to tell us about the new thing, the cement augmentation, how it works in osteoporotic fractures. And now as a complication of the anti-osteoporotic treatment, bisphosphonate related, the fractures which we are getting up. And then we might have the questions and discussions about it. So with that, first I request the gynecologist, Dr. Girija, to talk about.
Okay, good evening, everybody. We bring you greetings from Pune, India, and we have been identified as the hotspot for the COVID-19. But with all its disadvantages, I think the advantages, we are here together to discuss about osteoporosis. And yes, as a gynecologist, I am looking at this as a wonderful opportunity of learning from stalwarts like you who are here on the panel. But yes, always this thought has been that can gynecologists prevent many osteoporotic fractures? And looking at our practices now, I think the answer to this condition is yes. So this is me, Dr. Girija Wagh from Pune. Now, we all know that it's a common disease, as Dr. Ramesh Sen just now said, with a low bone mass, microarchitectural disruption, skeletal fragility, resulting in the increased risk of fragility fractures. And if you look at the global perspective, I think we speak about the hip fractures and the vertebral fractures, but what we very commonly see in the Indian context is the compression fractures of the spine, which are much earlier, which we experience, and then maybe move on to what we call as hip fracture. Earlier to that would be probably the wrist fractures. So looking at the global incidence, and in India must be having much more because unfortunately there is very less literature talking about this. We would have at least one fracture every 3 seconds. Now, as a gynecologist, we usually have women presenting to us with various common symptoms of menopause. And sometimes, unfortunately, in an insensitive situation, they may be warded off. Okay, it's just menopause. But I think that's a very wonderful opportunity which we are presented with, that, okay, fine, she's attaining menopause. She's brought herself to you for consultation. Maybe we must also consider about her risk of osteoporosis, because as she goes on moving away from the perimenopausal transition, we know that the osteoporosis risk increase. So if you look at actually the majorly two important issues in a menopausal woman would be the vasomotor symptoms, for which she would usually come, And osteoporosis would be a silent thing which she's not aware of and which the doctor should help her to find out. So when we look at this typical menopausal transition, most of the patients would be presenting around 40 to 50 years of age to a gynecologist with certain urogenital abnormalities, menstrual disorders, and things like that. And that, I feel, should be a window of opportunity where we can stand, make her risk assessment, and then maybe warn her and tell her that you have to keep on looking at yourself on a regular basis so that we are able to identify issues with you much earlier and maybe do little. I know there is very little that can be done to prevent these osteoporotic fractures. Now, these are the three important sites that we always talk about, and the lumbar, wrist, and the hip fractures. And there are various kinds of combination of bone health that we as gynecologists look at, from prevention to therapeutics to new horizons like the hormone replacement therapies, what I'm going to deal with, because I can see that there are many specialists here across the globe who are going to talk. I'll be speaking only to my particular perspective. Till the age of 50, 55, what we can do is prevention. Now, the osteoporotic landscape of India is absolutely hidden, and probability is that an estimated 43 million women suffer from osteoporosis in our country. And there are these very few publications in midlife health journals where they tell us about the incidences which they have observed in their small spaces. So the India-specific issues are early age of natural menopause, genetic and environmental influences, and nutritional deficiencies, and this is something very important, and excesses resulting in physiological differences. One of the other important components which I would like to put place in here would be even sarcopenia, and that is a question which I want to ask all of you. Is that having any role in having such a high level of osteoporosis, or can that be indulged into to prevent eventually the fragility fractures? Now, this all results in increased incidence of diabetes, cardiovascular diseases, osteoporosis. I know this terminology has to be revised. We now are talking of high or whatever low bone mass, thyroid dysfunctions, and genetic components have been identified where there are polymorphisms in the estrogen receptors, and that has been implicated in the pathogenesis of osteoporosis and serious lack in the preventive health, especially for women in our country. Now, another thing probably is also because of the changing lifestyle scenario in our country. Because the prevalence is found to be ranging from 25.8 to 62, and there's such a wide variation. And prevalence of low bone mass is more than 40% from the age of 40 years, easy to remember the numbers, increased to more than 62% by age 60 and 80% by the age of 65. And this is again due to inadequate nutrition, sedentary lifestyle, that's terrible. And one of the other issues which Indian women have is early menopause. Now, the fact that if you look at this calcium intake kind of a chart, and if you'll find that India has about the lowest kind of an average dietary calcium intake in their diet, and this not only sort of presence in the form of osteoporosis, but it also probably presents in the form of cardiovascular diseases, the risk for eclampsia, preeclampsia, and such conditions, and maybe even hypothyroidism. Now, there have been certain studies, and in the Aurangabad district, which is very close by to my Pune district, there has been this study where they studied the serum calcium level of pre and post-menopausal women, and it was found to be significantly low. And this probably has been identified as one of the reasons why would be causing osteoporosis early. And so naturally the question comes, do we supplement calcium, especially in the Indian context? Because if you look at the global perspective, we all know that much of the diet is replete with calcium, and so probably these countries do not find the need, but in our country we need to find them. Now, more than 61 million Indians have osteoporosis, and young and middle-aged Indian females are found to be osteopenic with a low bone mass, about 62.2%. And the risk factors, as we said, is parity, housewife, sedentary lifestyle, and poor nutrition. I don't know, something happened to my slide. Yeah. Now, and additionally, as I mentioned, low dietary calcium intake. And one more thing which has been identified, despite we being in a tropical country, we also have a very rampant vitamin D deficiency. Even in the context of pregnancy, preconceptional counseling, treatments, antenatal care, we find today that vitamin D deficiency seems to be influencing many parameters through the entire reproductive life of the woman's age. After the age of 50 years, it's been found that osteoporosis was only 16% in women who had the low income group, where they were consistently taking calcium. So naturally the question comes, should calcium supplementation be given compared to the low income group who did not have access to these calcium supplementations? So naturally, primary prevention would be probably starting from childhood. Risk of developing osteoporosis has to be asked for. Like we talk of cigarette smoking and inactivity, even in our country, we would say that we do not use cigarette smoking so often. It could be maybe just sedentary lifestyle. It's found to be equivalent to cigarette smoking. And additionally, tobacco usage is quite common in Indian women, and that can be contributory. There is no account of how much caffeine they're taking and how much less and malnourished diet they're taking. So the concept of peak bone mass has been much understood in the context of bone health, and it has been found that it is the result of the interaction of various factors: genetic, hormonal, racial, nutritional, lifestyle, and physical exercise. And environmental factors modulate the expression of the genetic potential to achieve the peak bone mass. And this probably determines how is going to be their susceptibility to osteoporosis and consequently fractures. Now, it's been believed that it is achieved, and it's been found that it's achieved by 25 to 30 years of age, while that is the time when women are usually facing their reproductive issues. 40 to 50% of the bone mass is accumulated during the pubertal years, and 80% is achieved by the age of 18 years. Now, this is the time where we are now afflicted with malnourishment on one side, childhood obesity on the other side, and now we have, in addition, polycystic ovarian syndrome. Asians, therefore, probably have a significant lower PBM, and calcium intake seems to be a main nutritional determinant. And in children and adolescents in whom calcium intake is deficient, calcium supplementation may help. And that is where probably we as gynecologists can be putting forth, because even in utero, we can help improvise the maternal lifestyle, because it's been found that the maternal lifestyle, the body build, and her vitamin D deficiency are responsible for the developmental origins of the osteoporotic fracture programming. And that is another window of opportunity which we as gynecologists definitely have. So if we can modulate the maternal nutrition and in utero influences, much of these incidences can be reduced, is a belief that we have. However, this requires to be addressed through various studies. And then there has to be an awareness about the calcium sources, not only through the supplements, but even through dietary modalities, because it's been identified that they're supposed to be the best sources of calcium and vitamin D through the diet. And the recommended allowance is, of course, for women 400 milligrams per day, in pregnant and lactating women 1000 milligrams per day, infants 500 milligrams per day, and adolescents 600 milligrams per day. We are seeing so many patients coming with polycystic ovarian syndrome, very common in our country, hypothyroidism, menstrual abnormalities. Unfortunately, much of our prescriptions do not talk about nutritional corrections, nor do they speak about supplements, and I think that is another window of opportunity. Now, when we talk of vitamin D3, another thing which is important is that we have to ensure that they're taking the correct form of the vitamin D3. It is an active form, and it is going to be helping in absorption of the calcium that is taken by the patient either through the diet or maybe even through the supplements that we give them. And it is also been found to be an important treatment for post-menopausal osteoporosis. I know we have experts who are going to talk about it. Now, coming to my sphere, we also talk about giving hormone therapies. Now, replacement is no more the word we use. We talk of hormone therapies, and most of the times these are given for relief of menopausal symptoms, especially the hot flushes, sometimes for prevention of osteoporosis, and to maintain the quality of life in menopausal women. Now, the various options that we use are estrogen, either oral or transdermal. Transdermal is much preferred by many women, especially women who are at risk of impaired hepatic functions or hypertriglyceridemia, which is very common in our country, because that interpretation also has to be right in our Asian context. We cannot use the same global standards to look at the dyslipidemia. And this transdermal, however, is not very commonly appreciated in our country, because naturally we are a tropical country. And of course, estrogen would be restricted in women who are still having the uterus intact, and therefore we would choose something else, or maybe give them a progesterone rescue. But another important block which has come up for this particular therapy is the rising incidence and the fear of the breast cancer, which has been, sort of published through the WHI trials. And therefore, we now are a little wary about giving this kind of supplements. And many times patients do not want, because they immediately would go and Google and find out and let us know. But whenever we look at the risk stratification and then we choose a woman in whom we can give, we are usually using estrogen 0.625 milligram, which is a conjugated estrogen or micronized estradiol. Progesterone is given in addition to help protect her breast, not to much extent, but definitely the endometrial hyperplasia. Or earlier sequential combined regimens of estrogen progesterone pills are given. I'm sure that this is something which orthopedicians, I don't know how much they would be interested in finding about these things, but these are the therapies that we are giving to these women. Now, another important aspect which we can consider is trying to reduce our oral intake is giving a progesterone intrauterine device in the form of an LNG IUS, that's a levonorgestrel intrauterine system, which is inserted inside the uterus in a woman who has intact uterus. And then she is given a transdermal estrogen therapy, would help her to protect, and especially would balance out those women who are at risk of thromboembolism and hypertriglyceridemia, and especially obese women with metabolic syndrome. Now, these are the various risk factors which we have to look at and have to ask for. And I think, like we have so many checklists for various other things, at the 40-45 years of age, we must also have checklists for risk factor reduction of osteoporosis. And that's how the gynecologist can play a role in trying to prevent osteoporosis, if not at least the osteoporotic related fragility and extensive osteoporotic related issues. And if these are taken into account, and I think inactivity is one very important thing which we require to ask. I know the government of India has come up with guidelines for physical activity, what is going to be optimum for the particular age. Unfortunately, it is not disseminated widely and none of us are aware about this. And once we look at the various clinical risk factors, which has been spoken of in this particular publication, in the Indian context, I would like to always add also about the fertility treatments, because we are using infertility very rampantly. Most of our women are obese, hypothyroid, and we are pushing in a lot of gonadotropins, and they are, and probably that would be considered by my colleague here on when he's going to speak about the glucocorticoid therapy, because that's going to be a similar kind of an action there. So as I mentioned, screening for osteoporosis is a window of opportunity which we can use, and then identify women at risk, educate them, and try to prevent them. And then all these things, maybe the things that are in our hands is trying to give them supplements, guiding them for their lifestyle change, and telling them about this, and then using the various therapies that we have. Now, we as gynecologists, as a part of our menopausal workup, usually ask them to do a T-score once they cross more than age of 50. And then once we find that they are either having a low bone mass or osteoporotic kind of a DEXA scan, then we refer them to an orthopedic surgeon. That's what we do. And sometimes if women do not have an access to a specialist, then we also take recourse of giving them the supplements along with alendronate or aloxifene, that is very commonly used in our practices when we identify these things. So we use tibolone, the selective receptors, tissue estrogenic activity regulators, and selective estrogen receptor modulators. And prevention is brought about by various such supplements, talking to them about exercise, smoking cessation, and moderate alcohol consumption. And this is what we learn. Bone formative anabolic drugs like vitamin D, strontium rallentate, PTH, and fluorides. Usually these are not part of our prescriptions, but inhibiting bone resorption through estrogen, SERMs, biphosphonates, and calcitonin is something that we use when we have such patients. And these are usually the biphosphonates. I'm not going to go into details of this because I'm sure there are experts who are going to speak about it. And there's so many other bone resorption prevention and bone formation accelerating medicines. And I'm sure we are going to have a feast of sort of knowledge today from this panel. And we are all looking forward to listening to you all. So coming to the cases, this is Giza, a 52-year-old newly menopausal woman, has hot flashes, has suffered no fractures and no height loss, and average height and weight. You can see that she has a body mass index, which goes in the mildly overweight. She has an intact uterus, no osteoporosis in the family, and she has not undergone any BMD assessment in the past. Now, currently, if you see that her BMD test was done and it revealed a lumbar spine T-score of 1.8 and a femoral neck T-score of minus 1.5. And so the question is she having osteoporosis or is she having osteopenia? So I think we can have the panel, any one of us telling us about this and guiding us whether what we are doing is right or not. Yes, Dr. Ramesh Sen, can we help you?
Yes, I think Dr. Sanjay Vadada is here. He is in the best position to talk about. Dr.
Yes.
Sanjay? Dr. Sanjay, you need to unmute yourself. Yeah.
So there is, what is the age of the patient?
She's 52.
52. So this suggestive osteopenia, actually the T-score is between minus 1.8 and minus 1.5.
Okay. So in that case, now what do we do for her? Because she doesn't have other symptoms. She's only come to us with hot flashes.
So best would be in our case is we can give the calcium and vitamin D.
Okay.
And maximum, if you want, you can do the FRAX analysis, that is fracture risk assessment score, FRAX score.
Yeah, FRAX
So
score.
the FRAX score is suggestive of, say, the major osteoporotic fracture is more than 20%.
Yeah.
And the hip fracture chances of more than 3.5%.
Yeah.
Treatment. If not, in that you can just treat with the calcium and vitamin D, and of course the osteoporosis education. That is very, very important.
Yeah. So we can see that her absolute risk for an osteoporotic spine, wrist or hip fracture over the next 5 years would be very low and in the range of less than 0.12% if we follow the FRAX score. But all the same, we will have to give her an education, as you said, and make her aware of what it is. So this is what the WHO score tells us about the most fragility fractures in the postmenopausal women occur with a low bone mass and especially in osteopenia. And as you mentioned, these are the therapies probably would help her. Should we give her any of this? Hormone therapy, raloxifene, hormone therapy, maybe we will consider giving her for her hot flashes, maybe for a temporary period of time. Many women, even if we offer them estrogen, progesterone, they would still go for isoflavones. They still continue to believe in isoflavones, exercise, and as you mentioned, calcium and vitamin D. So anything in particular would any of the specialists here would want to say that? Should we start on anything preemptively in this woman?
And from the endocrinologist perspective, so HT is hormone replacement therapy.
Yeah.
Okay.
So we nowadays say hormone therapy because we don't want to replace
change the terminology. Okay, fine. So hormone therapy is indicated clearly when there is a vasomotor symptoms are prevailing or the bone issues.
Correct.
So we don't use, if you at all you want to target the bone, then you have a better agent to treat with for the bone rather than treating with the hormone therapy.
Okay.
And because that will require some of the investigation, very close follow-up and all these things. So if the patient is ready and doctor is ready to evaluate, definitely there can be answer for the ST. But I would like to prefer the exercise, calcium and vitamin D and education.
Okay. So more likely to have an adverse event from HRT over the next 5 years, sir, you can comment on this. Like venous thrombosis, myocardial infarction, strokes, and breast cancer, these are our concerns usually, than a beneficial outcome like fracture risk reduction and improved quality of life. And that's what you probably mentioned. Anything you want to add to this?
So, again, I'm telling the same thing. If the vasomotor symptoms are a problem, then first 5 years after the menopause, they can use the HT.
Okay.
If the vasomotor symptom is not a problem, then if we want at all for the bone health, we can use the bisphosphonate as a good choice.
Okay. So women who consume calcium supplements, that is 1000 milligrams per day, and vitamin D can slow the endogenous rates of resorption and prevent bone loss, especially when complemented by an adequate program. And then do we do a follow-up BMD in 2 to 3 years' time in this woman? What should be her BMD screening protocol?
Yeah, well, first the calcium and vitamin D. Yeah. So calcium supplementation, as you also mentioned in some of the study, and we also did a small study that is 1400 patients in the from age ranging from 20 to 80 years. The
Okay.
average calcium intake in our group was less than 400 milligram. So this study was performed at PGI Chandigarh,
Yeah.
and Chandigarh is the part, say, surrounded by the Punjab and Haryana, where
Yeah.
the milk is the one of the common product which is used, or the milk product is commonly used. Still, if the calcium intake is less than 400, meaning by that elsewhere I presume that there is a calcium is deficient in the diet. And the
Okay.
recommended calcium is by diet plus pharmacological is approximately 1000 milligram. So if as unable to take the 1000 milligram of calcium intake by oral route, and that is of course a difficult, so better to give at least one tablet of calcium, that is 500 milligram, and remaining can be supplemented with the oral diet.
I
So
wanted
that
to
is
know
there.
that, yeah, that's one. Thank you so much. I wanted to know how many times do you frequent, what should be the frequency of the BMD analysis once we have diagnosed them to be having low bone mass at the time of menopause? So, do we recommend anything? Has that helped us in bringing down the incidence of osteoporosis, or maybe identifying earlier? What should be the, because she's now not menstruating, she's menopausal, she's 52.
Yeah. So I think follow-up BMD is 2 to 3 years quite reasonable, especially in this particular patient where she is having osteopenia.
Okay.
So if it is having the normal BMD, in that case, they should be follow up every 5 years, not before that with BMD.
Okay.
But if it is osteopenia, you can use 2 to 3 years.
2 to 3 years. Okay.
Yeah.
Thank you so much, sir.
Yeah.
So,
Thank you, Dr. Girija. I think we need to move
yeah,
on. We won't be able to take the next
yes,
one.
yes, no problem.
So thank you. Thanks a lot for a
Thank
very nice case. Now I'll request Dr. Shashank to talk about glucocorticoid-induced osteoporosis.
Good evening, everybody.
Dr.
Yeah.
Sen, just a
Yeah,
minute.
please.
I have a question to Dr. Girja.
Yeah,
Please.
You mentioned vitamin D in one of your slide about the calcitriol.
yeah.
So calcitriol is, I think, is not advisable,
Okay.
and endocrinologists are very unhappy with
Unhappy.
this
Yeah.
calcitriol because that is an active vitamin D,
Okay.
and that is not a supplement. That is a kind of drug, and
Okay.
it should be used in a particular indication, not for routine as a vitamin D supplementation. One is it is having more cost. That is the major issue.
Okay.
So I think we should avoid the calcitriol, which is active vitamin D. Yeah.
Okay. Yes. Thank you so much, sir.
Thank you.
Good evening, everybody. Great to be here with all of you today. Today we would be discussing about glucocorticoid-induced osteoporosis, something that is very commonly seen in my field of rheumatology. Right at the outset, I should say that this is probably one of the least proactively managed conditions across specialties. Let's have a look at what is the extent of this problem. Approximately 1% of all adults and 3% of adults older than 50 years of age receive glucocorticoids for allergies, inflammatory conditions, or cancer. That's quite a big number. Risk of fracture increases with age, dose, and duration of glucocorticoid use. What does it really affect? Vertebral fractures are the most common fractures. Contrary to most beliefs, risk of fracture starts within 3 months. So it's not a function of chronic glucocorticoid therapy. The risk starts increasing within 3 months of onset of therapy, peaks at 12 months of therapy. What dose is significant? We generally consider a dose of up to 7.5 mg of prednisolone in rheumatology as a physiological dose, which is technically considered as a low dose glucocorticoid therapy. However, as far as osteoporosis is concerned, this is still a significant dose. So 2.5 to 7.5 mg of prednisolone daily, the relative risk of clinically diagnosed vertebral fracture doubles, and the risk of hip fracture increases by approximately 50%. So two important things. The moment the patient is started on glucocorticoids, the risk starts increasing almost immediately. And second, even a low dose of steroid doesn't really protect one from osteoporosis, something that is really important to understand for all of us. When it comes to rheumatology patients and osteoporosis, it is not just the glucocorticoids. The risk of osteoporosis can be because of three issues. One, glucocorticoids. Secondly, underlying condition itself. And thirdly, inherent factors in the patient, which increases the risk of osteoporosis. As far as glucocorticoids is concerned, high daily dose of glucocorticoids, as you can see, high daily, anything more than 7.5 is considered as high daily as far as osteoporosis is concerned. Cumulative dose of glucocorticoid, which is more than 5 grams, current or recent, that is within 3 months use of glucocorticoid, glucocorticoid associated myopathy because it increases the risk of falls, and glucocorticoid induced hypogonadism, which indirectly again increases the chances of osteoporosis. Secondly, as I said, the risk, a part of risk also comes from the underlying condition. Rheumatoid arthritis, due to the inflammation, hyperemia, causes local as well as generalized osteoporosis. Ankylosing spondylitis, though there is extra calcium deposition, though there are syndesmophytes, the vertebrae by themselves in many of the patients are osteoporotic. Inflammatory bowel disease, biliary cirrhosis, and lastly, as I said, the inherent risk factors related to osteoporosis: age more than 55, female sex, menopause, smoking, excess alcohol use, a T-score less than minus 1.5 to begin with, increased risk of fall, endocrine disorders, hypogonadism, hyper as well as hypoparathyroidism, malabsorption, low body weight, and a history of previous fractures. So what really, how do steroids really cause osteoporosis? In fact, there are multiple mechanisms. Glucocorticoids affect almost all the cells of the bone forming unit. It it causes increased osteoclastogenesis, decreases the osteoblastogenesis, and increases the apoptosis of the osteocytes. All of them together contributing to osteoporosis. It decreases the muscle mass. This, along with decreasing the strength of the muscle, increases the risk of falls and further fractures. Decreases the sex steroids, indirectly again contributing to osteoporosis. And lastly, also decreases the calcium absorption, thereby indirectly contributing to osteoporosis. So then, but obviously that would not stop us from giving steroids to our patients who really require them for genuine reasons. How do we go about when we start a patient on glucocorticoid therapy? One, this would, to begin with, would be a clinical fracture risk assessment, then followed by BMD and FRAX. So how do we go about? Suppose I start a patient on glucocorticoid therapy for a particular rheumatological ailment. The clinical fracture risk assessment should be done. These are the American College of Rheumatology guidelines for prevention and treatment of glucocorticoid associated osteoporosis. The clinical fracture risk assessment would be as early as possible, but definitely not later than 6 months of starting of glucocorticoids. In children, where the chances of osteoporosis are low, nothing specific needs to be done. We just have to clinically assess. Adults less than 40 years, if there is no history of prior osteoporotic fracture or other significant osteoporosis risk factors. Now, what are these other osteoporosis risk factors? Malnutrition, significant weight loss or low body weight, hypogonadism, secondary hyperparathyroidism, thyroid disease, family history of hip fracture, history of alcohol use, more than 3 units per day, and chronic smoking. So if these risk factors are not there, one need not do a BMD immediately. Eventually it needs to be done, but need not do it in the first 6 months itself. However, if any of these factors is there, one needs to do a BMD within 6 months of initiation of glucocorticoids. For adults more than 40 years, in whom the inherent risk factors of osteoporosis are more, they would be straight away getting a BMD as well as a FRAX, along with clinical fracture risk assessment within 6 months of therapy. How do we stratify the risk? Adults less than 40 years, meaning once you have done the clinical assessment, then a BMD, FRAX, and how do we stratify these patients based on the results that we have? For an adult less than 40 years of age, if there is a prior osteoporotic fracture, he would fall into high risk. If the Z score is less than -3 or rapid bone loss more than 10% at hip or spine over 1 year, this would obviously require multiple BMDs, but this is one of the factors which could be there in a few patients. And lastly, continuing glucocorticoids more than 7.5 mg for more than 6 months. This puts the patient in moderate fracture risk. Lastly, none of these is there. He would be in the low fracture risk group. As far as patients more than 40 years of age is concerned, something that Dr. Barada just referred to, with a frax, if the risk of hip fracture, 10-year risk of hip fracture less than 1%, or 10-year risk of major osteoporotic fracture less than 10% would fall in the low fracture risk. A 10-year risk of hip fracture between 1 to 3% or major osteoporotic fracture risk 10 to 19% would put the patient in moderate fracture risk. And a frax generated 10-year risk of hip fracture more than 3%, or the risk of major osteoporotic fracture more than 20%, or a frank osteoporotic fracture currently or in the past would put the patient in high fracture risk. So now that we have stratified these patients, how do we go about further? One, each and every patient would go get calcium, vitamin D, and lifestyle modification. What all would lifestyle modification mean? Balanced diet, maintaining good body weight, smoking cessation, regular weight bearing or resistant training exercises, and limiting alcohol intake to 1 to 2 alcoholic beverages per day. Somebody with low risk, something that we already saw, no further treatment is required. Calcium, vitamin D, lifestyle modifications are good enough. Those with moderate to high risk would require treatment. The treatment would mean oral bisphosphonates. If that is not tolerated, IV bisphosphonates. And the other options that we also have, teriparatide, denosumab, raloxifene, if nothing else is available or patient is not has issues with the other agents. So this was about how do we go about the treatment in these patients. Obviously, there would be some special situations. What if there is an initial treatment failure with oral bisphosphonates? Age more than 40 on glucocorticoids has a fracture after 18 months of bisphosphonate therapy, or has a significant decline in BMD more than 10% per year after 1 year of therapy. That would mean we have to shift over to other osteoporosis medication class. It could be teriparatide, denosumab. And if you suspect that compliance with oral bisphosphonates was a problem, one can go in for IV bisphosphonates. What after 5 years of bisphosphonate therapy? This is a common problem all of us face. We have already, the patient is on glucocorticoid. Patient has already been on oral bisphosphonates for 5 years, taken seriously, sincerely. Then what to do after this? If the age is more than 40 on glucocorticoid therapy and completed 5 years of bisphosphonate therapy, you can still continue oral bisphosphonates up to 7 to 10 years. One can switch to IV bisphosphonates if compliance is an issue. The third option is you can switch to other osteoporosis medications like teriparatide, denosumab. Here, you need to consider the risk of jaw necrosis or atypical fractures while continuing the bisphosphonate therapy. But the message, take-home message is, if the risk factors continue, you can continue bisphosphonates for 7 to 10 years after considering the risk of jaw necrosis or atypical fractures. And this again is preferably a shared care decision where the patient is an equal partner in the decision. What after discontinuation of glucocorticoid therapy, tomorrow the patient does not require. In fact, frankly, one thing from the rheumatology perspective, more and more patients are getting off glucocorticoids now. We have come a long way as far as rheumatology medications are concerned. Even patients of lupus, the trend, the thought process today is they end up with more problems related to glucocorticoids in the long run more than the disease itself. So even in lupus, we are trying to cut down and stop steroids as early as possible in today's world. So once I stop the glucocorticoids in this patient, what do I do? If the fracture risk is low, we can stop the osteoporosis therapy and just continue with calcium and vitamin D. Otherwise, continue therapy till the time the risk is assessed to be low. Over to you.
Thank you, Dr. Shank. Now, it is very difficult to perceive that we can talk a lot about whole osteoporotic problem as an endocrinological perspective, but still I'll request Dr. Sanjay to sum up his perspective in next 10 minutes. Something, Dr. Sanjay, please.
Dr. Sanjay, can you share your screen?
Yeah. Just a minute. So I'm just struggling a little bit. Yeah. So I have to share the screen, something like that. So
Till the time some screen is shared,
is it okay?
just what you waiting for?
Just a minute. Mm,
Just put on the slideshow now.
yeah, slideshow. Just a minute. Why it is not showing slideshow? Yeah, it's okay. Can I start?
You can start now, sir. You can start.
Okay. So, very good afternoon and rather evening in this pandemic of COVID-19. There's new experience to learn from each other, and thank you very much for the opportunity that stalwarts are here to contract with each other. So that is what I was thinking. Slides. Yeah. Slides are not moving.
No, slides are not moving, I think.
No, slides are not moving.
Yeah, I can
So
see.
what I would suggest, just with the mouse, tap on the slide, take the mouse or the trackpad onto the slide, click on the slide, it will start moving. Yeah. Now just try the arrow. Click first. Yeah. Yes.
Okay. So anyway, this is the sculpture 1885. So what Dr. Girja was telling is that osteoporosis is not a new thing. And this particular picture, you can see that how osteoporosis looks like. Well, there's a lady, the beautiful wife of Hamlin, king from the Austria. And you can see that she is having the hunchback, she is having protuberant abdomen, and she is having the loss of fat pad in here. So that is very much suggestive of the osteoporosis. The person Fuller Albright is also known as the father of modern endocrinology. Actually, the person is giving the term osteoporosis, what we are talking on that. So coming to the straightforward, the my talk related to the osteoblast stimulators or the osteoanabolic agent for the management of osteoporosis. Before going to that, that is a brief history about the parathyroid hormone. So this parathyroid hormone is actually secreted from a gland that is called parathyroid gland, which gland is present in the neck and it is parallel to the thyroid gland. That's why it is named as the parathyroid gland. And you can see here is Indian rhinoceros, the brief history about the so this Indian rhinoceros actually sustained a fracture. So it is very unusual to rhino to develop a fracture. So this rhino was subjected for the autopsy and they found that the 4 glands were there. There's almost size of the tomato parallel to the thyroid gland And how this came, it is the parathyroid gland. This parathyroid hormone was first excreted and used in the 1920 for the rodent, and in subsequently 1932 it was shown that it is having an anabolic effect. But in general, people feels that the parathyroid hormone is actually causing the bone resorption, not the bone formation. But in 1970, it was confirmed that parathyroid hormone can increase the bone density if it is given in the intermittent fashion. So the modern history, by 1993, the parathyroid hormone was used as a subcutaneous administration, and subsequently in the 2002 November, US FDA approved for the treatment of osteoporosis in the men as well as in the women. Now coming to the what are the indication of teriparatide therapy. So there are the certain indication for the teriparatide therapy. One is severe osteoporosis. When we talk the severe osteoporosis, meaning by that bone mineral density T score is less than minus 2.5 with a fragility fracture. So that is defined as the severe osteoporosis. And the osteoporosis, we know all that the T score is minus 2.5. That is for the postmenopausal woman as well as in the men, as well as similar term is used for the glucocorticoid induced osteoporosis, where the T score is considered, rather G score is considered minus 2 actually. Then this drug is used by the orthopedic surgeon for the fracture healing, though there is no large, long-standing studies are available. Can be used for the bisphosphonate failure, can be used for the atypical femoral fracture, can be used for osteonecrosis of jaw, and a very recent indication is used for the hypophosphatasia. So teriparatide, which is available in the market, is a potent anabolic agent, and it is also known as recombinant human parathyroid hormone. It has a uh, amino acid 1 to 34, is an N-terminal fragment of parathyroid hormone, and it stimulates the bone formation, and it is mode of action is actually pharmacological, not physiological. How this drug is prescribed? It is prescribed once daily injection, that is subcutaneous, 20 microgram per day. Total duration of therapy recommended is 18 to 24 months. Remember this drug cannot be prescribed more than 24 months. The reason is that there is a theoretical risk of developing the osteosarcoma, though there is not a practical risk of developing the osteosarcoma, because there is a difference in the human skeleton and the mice skeleton. Is that human skeleton usually does not grow after 18 to 20 years of age, while the skeleton of the mice is grow throughout the life. And that is the reason for this, the mice develops the, or the rats develop the osteosarcoma, but the risk in human is very less. And the problem, it is injectable and does not increase bone mineral density at the forearm. Now we are in the state of the COVID pandemic. So this drug is usually recommended for 18 to 24 months. But if the person taking the recombinant PTH, and if he is unable to procure the PTH right now for a few weeks, then they can continue this drug for few more weeks till they get the drug, or they can be infused with the, after the teriparatide completion, with the bisphosphonates or with the denosumab. So here is the brief mechanism of action, that how the parathyroid hormone act on the, to increase the bone mineral density. So you can see here that the PTH, which will actually helps in proliferation of mesenchymal stem cells. These mesenchymal stem cells further act on the early osteoblast. This early osteoblast further converted to the late osteoblast, and that is all these actions are actually mediated by the parathyroid hormone. Subsequently, this parathyroid hormone also act on the osteocyte and inhibits the sclerostin and the DKK1. This sclerostin and DKK1 actually inhibits the WNT signaling pathway, and this pathway is actually acting on the late osteoblast and the responsible for the bone formation. So PTH actually inhibits these two cytokines, that is sclerostin and DKK, and that will indirectly help to promote the osteoblastic activity. Now, what are the indication? As I already mentioned, that the indication for the teriparatide are severe osteoporosis and osteoporotic fractures. What are the prerequisites before prescribing the teriparatide? First and most important is a detailed history, as in any medical condition, and you rule out any malignancy or pre-malignant condition, because the teriparatide is contraindicated any malignancy. So you must be seeing lot of patients with the breast malignancy receiving the bisphosphonates and other drugs. So if there is a baseline history of malignancies there, this drug should not be prescribed. Second is the calcium profile. So all patients before going for a prescription of teriparatide should get complete calcium profile, that is calcium, phosphate, albumin and alkaline phosphatase. They must have the PTH and vitamin D, because any at baseline the PTH is elevated, this teriparatide is contraindicated. And the best example is that the osteoporosis and primary hyperpara can present in the similar manner in form of the fractures. And the vitamin D should be normal before prescribing the teriparatide. Alkaline phosphatase should be normal, as well as PTH I mentioned, and rule out Paget's disease, history of bone radiation, malignancy, bone metastasis, and open epiphysis. That's why this drug should not be prescribed below 18 years of age. So these are the prerequisites before prescribing the teriparatide. Now I'll take you an interesting case of the patient of the osteoporosis or the say facility fracture. So you can see a 50-year-old male. He has a history of fragility fracture, and he treated with the hip implant and the recombinant human PTH. After 6 weeks, he sustained another fracture, that is the left hip fracture. And in fact, with the starting of the treatment of the teriparatide, his condition further worsened. And when we asked for the biochemistry of this patient, actually this patient has a phosphate of 1.2 and the TMP GFR of 1.5. So among the audience and the panels, is there any change in the diagnosis, or would you like to treat with the different modality rather than continue with the teriparatide?
I think it is better for you to clear it out the doubts, because
Okay, fine. So what happened, this lady, this, you can see the picture of this x-ray of this patient. So you can see the bilateral hip replacement. I doesn't know much about the hip replacement, but at least this picture is showing the patient underwent the bilateral hip replacement. And then you can see this picture over here, that this patient has a pre-operative, this kind of feature is there. So there is coxa vera deformity, and there is head of the femur is since that say detached from the neck of the femur. And this was this FDG scan of this patient, and you can see that there is a uptake in this area. And then you can see the bilateral femoral neck fracture is there. So this patient actually had the basically hypophosphatemic osteomalacia. So you can see the picture, this biochemical profile here, that this patient has a phosphate of 1.2 only at presentation, and the FGF23 was elevated. So the diagnosis was actually the tumor-induced osteomalacia, and this patient was treated with the resected this abnormal lesion, and this patient improved. Now patient is walking without support or anything. The message from this particular case is that before prescribing a costly medication or planning for a hip replacement, I think we must look carefully for the calcium profile and remaining biochemical profile to rule out any other cause for the osteomalacia. So this patient actually giving a two message, that even if the BMD will be low, that BMD will be low in case of the osteomalacia as well, because your DEXA scan will not help you to differentiate between the osteomalacia and osteoporosis. That will just simply tell that patient is having a low bone mineral density. So this is not an uncommon problem. we come across such 1 to 2 patients at least in a year with this kind of treatment. So PTH has effect on the cortical bone as well as on the trabecular bone. So you can see that it increases the trabecular thickness, it increases the trabecular connectivity, and that is nicely, you can see the pre-treatment, the bone biopsy will looking like that, post-treatment it is looking like that. So the teriparatide is effective. Now how to monitor this patient is that you need to monitor by the serum calcium after the first dose, maybe third or the seventh day of the teriparatide treatment. You can monitor by the bone markers. DEXA is recommended after 1 to 2 years, not before that. But cost and compliance is a major issue with the teriparatide. And the side effects common are transient hypercalcemia. It resolves spontaneously. If it does not resolve, stop the calcium. Still does not resolve, then you can stop the teriparatide for 1 week or 2 weeks, then you can restart. And the osteosarcoma, as I mentioned, is a theoretical risk, not it is a practical risk, that so far there is almost 2 to 3 million patients are treated with the teriparatide. Just 1 or 2 patients are reported with osteosarcoma. So that is actually maybe lesser than the general population rather than treated with the teriparatide. So follow up these patients with these clinical, biochemical, bone markers and bone mineral density. So the problem with the teriparatide is it invasive, high cost, poor patient compliance, painful delivery, and need a healthcare professional for the injection. So what should be the future teriparatide? So can we use teriparatide as a weekly therapy? So what we did is we used the teriparatide as a weekly therapy. Here you can see that here is the bone marker, as bone formation marker, is the bone resorption marker. So you can see that at the baseline, when we started treated these patients with weekly teriparatide, that is the bone formation level is started increasing. It went up to the 6 week in the daily group. So there is, this area is called anabolic window, and this anabolic window is coming at the end of the 12 months. When we treated this patient with the weekly teriparatide therapy, and you can see that this anabolic window is open still at the end of the 12 month. When these patients were treated for the 2 years, and you can see that anabolic window is open still at the end of the 24 months by weekly teriparatide therapy. And the same is, we had a publication in one of the journal. So this weekly teriparatide versus daily teriparatide, how weekly teriparatide is better? So it is better in form of, it is comparable or better to daily teriparatide therapy, because it gives better compliance, because you have to use the drug once in a week. And since this is a once in a week, so you are giving the lesser dose, so you can use this drug for more than 2 years. And I am sure it is very cost effective and very patient friendly also. So these are the various other indications other than the osteoporosis to treat with the teriparatide therapy. One is that atypical femoral fracture. It is very common for the orthopedic surgeon. I'm sure they must be seeing at least 1 to 2 patients in a month. So you can use that. Rare problem, osteonecrosis of the jaw. You can use that for this therapy. And further rare is the hypophosphatasia. The suggestion to the all orthopedic surgeon is that when you see a patient of femoral fracture or the subtrochanteric fracture, look carefully for this beaking. And this beaking is either with the teriparatide, either it is the bisphosphonate therapy, or it can be there in the hypophosphatasia, where the alkaline phosphatase level is low. If the ALP level is low, the condition or the diagnosis is the hypophosphatasia. So before prescribing bisphosphonate therapy or teriparatide therapy, ensure that what is the correct diagnosis for this fragility fracture. I'll spend few minutes on the fall prevention, because that is very, very important. Because if you prescribe a costly medication, if you are not talking about the fall prevention, I think it is not acceptable. So tell your patient about the education. These are some of the pictures from my institute. So avoid walking on the uneven surface. preferably osteoporosis patient should walk on the even surface. Very common, this is a practical issue. Here you can see the person is riding on the scooter and the pillion rider, and she is sitting both legs on the one side. There is more chances to fall as compared to if the person is sitting in like this. It is a very common in India because the ladies often sit behind is a pillion rider and they are keeping their both legs on the one side, and there is a chances of fall. Then in the hospital, patient of osteoporosis should not walk in this area without railing. There is a chance of slippage, so always have something to hold in. Then even in the lifts also, there is the railing here, there is no railing here. So they should use the lift which is having the kind of support while standing in the lift. Then this is a very common, everybody knows that the house should be in the order to prevent the fall on this skipping. Very common for the amongst the Indians that we use, for everybody we use the slippers till the end, and it is not advisable because that will make you more prone for the slipping as compared to this kind of the relatively better slipper. Then say bathroom is the site where the maximum fracture takes place, so it should be cleaned like this, not like this. Then the bathroom also should have the electric switch outside, which is wrong. It should be outside because once the person will enter into the toilet, if the light is not lit properly, there is a chances of fall is there. So this is a correct way. Then this is the picture one of bathroom. What should be the bathroom equipped for the osteoporotic patient? So you see here there is a chair, but I feel that we should have a better chair here rather than the plastic chair because the chances of slippage here. This bucket is in the reach, the shower is in the reach, the mug is in the reach, and the all required items in the reach of this uh, chair when the patient is sitting and they're taking bath or here. Or similarly for this kind of arrangement for while using the toilet for the defecation, there is handrail here that can use while getting up and sitting on the chair. That is very, very useful. So I'll end my presentation here by saying the famous few dialogues by the Fuller Albright. I have told you more than I know about osteoporosis. What I have told you is subject of change without any notice. I hope I raised more questions than I given the answers. In any case, as usual, a lot more work is necessary to treat the osteoporosis and manage the osteoporosis. Thank you very much for your patience listening. If there is any question, comment, I will be happy to take them.
Thank you, Sanjay. We are all likely to question subsequently where we'll have all the questions. And I'll ask Dr. Mahesh to come up with his work, with his advice radiologically in the patients of osteoporosis when we are talking about. Can we have Dr. Mahesh, please?
Hello.
Hello.
My the video is not working. So am I audible?
Yeah,
yes, he has not come up because Dr. Sanjay has to stop screen sharing.
Okay.
Okay, just a minute. Yeah, stop screen, stop share.
Yes, now Dr. Mahesh, you can share your screen.
Yeah. Is that okay? Can you see it? Okay.
Yeah.
So good evening, everyone, and thank you, Dr. Sen, and everyone to providing me the opportunity. He told me that you limited the time for 10 minutes, so I know. So I have to be will be telling you about only the basic things. So we all know that you guys all know about it, that what is the osteoporosis. I am not going to detail about the what is osteoporosis, but important thing to remember that the osteoporosis not only having the low bone mass, but there is a microarchitectural deterioration. So, and that's why it's increased frequency of fractures. The important point to remember here that the radiology not only provide the diagnosis, but it helps for the clinicians for the prognosis as well as in the management of the patients. So look at, if you look this slide, these are the imaging modalities for the assessment of the bone. So like here, like if you want to see the structural changes in the bone, then these are modalities are available, the X-ray, CT, and MRI. And if you want to see, you want to assess the mass or the density, then we have the DEXA, we have the QCT. Am I audible, sir? Because I am not able to see here from here.
Yeah, quite okay. You
It's
can just
okay.
go for a slideshow, or you can go for a speaker view, then you will be able to see us also. I don't think so.
Is that okay?
Yeah, quite good.
Okay. So this is the very important, the table here. Like we want to assess the structures here, then we have X-ray, CT, and MRI. You want to assess the density, bone density, and the bone mass. Then we have some modality which include the DEXA, which is most importantly we are doing, everybody is doing. Then we have the quantitative ultrasound. Then we have a quantitative CT scan. Then important thing again is to evaluate how to evaluate the architecture of the bone. So then we have a like newer techniques in which we can assess the high resolution by the high resolution MRI and the CT scan, the architectures. And if you want to evaluate the metabolic activity, then we have a bone scintigraphy and the PET. So these are the things which remember by the, like if you want which part of the bone strength or bone abnormality can be assessed by the different modalities. So this is a long table, here, the long list of the imaging modalities are available. Some are were the previously done, but predominantly nowadays we are usually limited to ourselves the radiography, the plain X-ray, which is the very initial modality and usually done everywhere. And it's quite cheap also. Apart from the radiography, we usually do the DEXA. The QCT sometimes is being done in some of the places, but not routinely is done, but the DEXA is most commonly done. Then the quantitative ultrasound is being done in the if you want to assess the large number of people and people. Then the MRI has a role for evaluating the osteoporotic fracture versus the other fractures, particularly in the spines. And these are the high resolution imaging like CT and MRI. This is a more of like for the research purpose. So basically it's not being done routinely, but routinely what are the modality? Radiography, the DEXA, QCT, and then MRI. It's being done in the. So let's see what can be seen on the plain radiograph. That these are the radiograph. You can see here the AP view of the lumbar spine and the lateral spine. Then you can see what are the abnormal finding. You can see the generalized osteopenia. Then we have a thinning of the cortex here. You can see the cortex are very thinned out. Then the trabeculae are lost. Then you can say the lot of can be seen the wedging. Then you can see the collapse of the vertebrae here. So these are the finding you can see on the plain X-ray.
This is not audible. There is some
This is
issue
not audible, sir?
near it. Now it's okay.
Okay, so these are the plain X-ray of the pelvis. We can have a generalized osteopenia, and then we can have the prominent trabeculae. If you want to assess the trabeculae, the Singh index is there. You can assess the trabeculae. Then we have the generalized osteopenia, and you can say have the fracture here in the left side, left neck of the femur. And apart from the osteoporosis. So what are the disadvantage of the radiography? You can see here the disadvantage is the subjective. Like many times we have seen in the clinical rounds also, like we see that say osteopenia, but the other radiograph can say, the radiologist can say that the osteopenia is not there. And it's affected by the body habitus, the radiographic exposure also, and the patient position. And then it's another important thing that like if the bone loss is more than 30%, then it's only appreciated by the plain radiograph. So these are the limitation of plain radiograph. So coming to the DEXA, this is most important and routinely being done for the evaluation of the osteoporosis. What is the like principle? We know that what is the we have a X-ray sources here. It produces 2 photon energy, and then assess the how much the attenuation properties are there, and then we subtract the images, and then we can evaluate the bone mineral density. So these are the machines we are having in our institute. In the hologic, we have a hologic DEXA machines here. So patient has to lie down here, and then, so what are the type of the DEXA? We have a central DEXA in which we have to see the lumbar spine, then we have to see the hip, then we can also do the whole body also. Peripheral DEXA include the evaluation of the forearm and the calcaneum, but the most commonly the DEXA is done the lumbar spine and the hip, because these are more like informative and useful for the clinicians. What are the contraindication of this, DEXA? Usually very, very limited. So in case of suspected pregnancy, or if some the administration of contrast is being done, otherwise the DEXA can be done in most of the cases. So these are the typical the DEXA the reports in the at the LS spine and here, and whatever we can take the Z score, the T score, and we all know about it, the how much the value of the T score is there, and how much when we call the osteopenia or when we call the osteoporosis. Similarly, we can do the DEXA of the femur also, including the femoral neck as well as the intertrochanteric region. And similarly, we get the reports of the DEXA of the femoral neck, similarly to the spine. So both of the spine as well as the hip region is usually is being done in our institute, but depend upon when the clinicians want for the peripheral or the whole body DEXA, that also can be done. So this is the table which Dr. Batata was also telling, that when to call the osteopenia and when to call the osteoporosis, we all know about it. So if the T score is between the -1 to -2.5, it's the osteopenia, and below that is the osteoporosis. So we have to deal about it, that how to treat the patient depend upon the bone BMD, the value. Coming to the computer tomographic, the quantitative CT scan here, what usually, like initially we were doing this QCT, but nowadays because we have the facility of DEXA, so we are not routinely done, but this can be done whenever is required. So this is like CT scan, the scanner here, patient has to lie down here, and then we have to take the scanner, the images, and then we have to take the section at the L1, L2, and L3 level, and these are the axial images, so we can measure the cortical as well as the medullary the mineral density here. And the typical report of the QCT is like this one here, and usually it has also the T score and Z score like the DEXA, and that can be measured by the QCT also. And this way, like this is the patient here, you can say this is the value of this patient here, so it's quite low, in less than -2 standard deviation, so in the form of the osteoporosis. Coming to the quantitative ultrasounds, is not routinely done and in our institute, but is probably done in more if you want to screen the more patients in the community. And the principle here is like usually you have to use the ultrasound transducer, and then we have to send the sound, and then how much of the sound of the ultrasound is attenuated, and then we can calculate the bone mineral density by the ultrasound. The advantage of the ultrasound are usually the complete absence of radiation, like in the DEXA, all the minimal radiation is there. CT is the more radiation there, but the ultrasound, there is no radiation. It's quick and it's portable and with low cost. But disadvantage of the quantitative ultrasound, there no standardized method of calibration. So many times we have seen the many the studies also, the variation is there, the values are much more there, so no standardization is there. That's why people are usually use the DEXA as a gold standard and being routinely used for the BMD measurement. Coming to the MRI is most widely used application of MRI in the diagnosis of osteopenia, not on the detection of the BMD, but like to see whether it is a osteoporotic fracture or there is a collapse or this fracture is because of the other reasons. because they usually many of the fractures are asymptomatic, or they detected by the region, like patient have a disc, the prolapse, or the so that's why on those situations we can see the collapse here, and the challenge for the radiologists and the clinicians whether this collapse of the vertebra is because of the osteoporosis or with the other causes. So MRI has a role for to differentiating between the osteoporotic fracture versus the other fractures. So this tables tells us that what are the point which goes in favor of osteoporotic fracture versus the metastatic fracture. Well, this is the most common differential diagnosis, particularly the older age group of more than 50 years of age. So this table is important for the radiologist, but just to mention one or two points here, that if you have a sharp angulated margins and pedicles are not involved, that is more likely osteoporotic. When there is a soft tissue component is there in the case of the fracture, the collapse is there, then this is more likely osteoporotic. In metastatic or the infective process, usually you can see some collections or some soft tissue component, and there is some the signal changes also there, which by which these are the relative points which we can say probably we are dealing with the osteoporotic fracture versus the metastatic fracture. So this MRI has a role to differentiating these fracture, osteoporotic fracture versus the other fractures, and the radiologist has some clue about it. Apart from that, the conventional T1 and T2 weighted sequences, we have other sequences like the diffusion weighted imaging and the dynamic contrast enhanced imaging. That way we try to differentiate. Although on 100% cases we cannot differentiate, but there's some of the points which usually we take in consideration if we are thinking to differentiate between osteoporotic and metastatic fractures. See one of the cases here. This is osteoporotic collapse here. You can, this is T1, T2 weighted sagittal images here. This is a T1 weighted image here. This is the collapse of the vertebrae, which show the lower, the hypointense signal on T1 and T2 weighted images. There is no posterior bulges there, and on T1 and T2 images, they even say the similar signal intensity. So not a much hyper intensity here. So we can say probably we are dealing with the osteoporotic collapse. In differentiating between the metastatic collapse here, you can see this the vertebra, this collapse vertebra is there, and you can say there's a hyper intensity on T2 weighted images. There is a posterior bulge is there, which is causing indenting the spinal cord here, and the T1 weighted images showing the signal intensity, which is intermediate. So probably these are some of the features which can differentiate, and MR has is a very important role. So just to conclude and to see that what are the advantage and disadvantage of the particular modality, like if you see these DEXA, the advantage of DEXA is high precision, low radiation, is very rapid, is done within the minutes, and you can select the multiple sites also. Like you can do the peripheral, you can do the central area, you can do the hip area, you can do you can do the whole body also. So if you want, like some of the, like it depend upon the clinician which area you want, and then you can get it done. So it's because very quick, so it doesn't take too much time. The limitation of the DEXA is the sometimes because of the overlapping of the osteoarthritic features or the aortic calcification. The value may not be very correct because it's two-dimensional. So these are the quite limitation, but still the DEXA is very important, and the gold standard routinely done in most of the places. If you consider the quantitative ultrasound is also very cheap and rapid and easy to perform, and there is no radiation on the ultrasound. But the limitation of the quantitative ultrasound is the low sensitivity, and there is no standardized calibration. So these are the two things are limitation. That's why the ultrasound is not usually used in the clinical practice everywhere. If you see the quantitative CT, that is called QCT, is a most sensitive, and apart from that, it has a three-dimensional assessment. Because so there is a three-dimensional assessment, so there is no overlap things like here in the DEXA, there's overlap is there, and then the value can be changed or can be misleading. Here is the 3D dimension, the assessment can be done. And another important thing here is that the separate measurement of the cortical and cancellous bone can be done by the BMD, and then the limitation is expensive and more radiation exposure. These are the limitation. So these are the things like people usually ask what is the comparison between the QCT and the DEXA. The people have done some of the study, even one of the study we have done in one of the institute, our institute also, and we found that probably the findings were nearly similar. But considering the availability and the gold standards of the DEXA, so usually the DEXA is will done more frequently. But the apart from the cancellous and the cortical bone changes, usually the BMT the measurements are nearly same. So I'm just completing that the radiology, the things, the radiology, the modality starting from the X-ray, the QCT, the DEXA, and the MRI. They helps in the not only the diagnosis but in the management of patients, and very very useful for the clinicians to make the assessment and to treat the patient. Even they can follow up these by particularly the DEXA, then the patient is improving by giving the treatment. So so that's from me. Thank you.
Yeah, thanks, Dr. Mahesh. Considering the time constraint which Dr. Pepe has got it, so I'll request Dr. Hans Chris Pepe to slide with his projection, because he has given us a limited period. Because he's still working over there in his hospital, so the time is limited for him. So I want him to speak. Dr. Pepe, please.
So let's see what we can do to share the screen.
Yeah,
can you hear me okay?
Yeah, surely, sir.
Yeah, we can hear you.
All right. So good afternoon, good evening, everybody. I have a rather specific topic, which is cement augmentation in orthopedic surgery. We deal with the osteopenic bone, and one of the options is to improve the situation so that the metal can hold inside the bone is to use cementation. And first of all, I'd like to give a little overview, and I'll focus on the humerus and on the femur. In general, the orthogeriatric co-management has been something very new. Since about 10 years ago or so, it became more and more popular. And it's really difficult. At first, it appeared to be difficult to put these people together, because orthopedic surgeons have rather a nice way of communicating like guys, whereas geriatricians have a lot more knowledge, and they probably communicate a little bit like this. And then most importantly, surgeons are in the operating room. And so many of the small pieces of information they're unable to pick up. A few years back, we did an overview and looked at what is going on in proximal femur fractures. And so one of the issues was that obviously the reduction was felt to be difficult more in level 1 trauma centers, whereas the implants and the surgical technique appear to be more important in level 3 hospitals, which are smaller hospitals. And the most interesting aspect I found is 3/4 of the surgeons have never used cement for cementation. As you can see on the left-hand side on the X-ray, you can see some metal, and it is surrounded by cement, just like you do for prosthesis. So when and how do I do it? Do I do it around the implant? Do I do it through the screws? And some possible dangers. One of them is heat generation. So people have felt that maybe it destroys or disturbs the cartilage. And the other danger would be a penetration of the cement into the joint, especially if you do it in the proximal femur. Now, some biomechanical studies have been undertaken, and there are some principles of cementation where you can see that the uncemented screw didn't have the same purchase as the cemented one. Just because the cemented one, you can see on the right-hand side, it nicely it distributes around the tip of the screw. So this was just a biomechanical study. We actually did one in the proximal femur. And so if you look at some of the literature out there, you can see that in general, people support it. So it gets a thumbs up. So this is the study that we have been doing in our hospital. It was also a cadaver study, and what you could see is that we tried to do failures, and what happened without augmentation was penetration into the or through the cortex, whereas when the cement was put around the screws, we actually put it into the screw holes. You could see that when the implant failed, it would break at the area of the shaft. So here's some other studies. They also did cementation independently of the screws and felt that it is helpful. If you look at the more recent literature, you will find that regardless these studies in the proximal humerus, it is not really used any longer. But so the studies that have been 8 to 10 years old, they kind of supported it. The most important area is probably the proximal femur. And here you can see a set that has been used by Depuy Synthes for cementation. So basically, all the studies that you can see about cementation in the proximal femur will have to have used PFNA because it's the only one that works. And here you can see some biomechanical studies. As far as the clinical studies are concerned, there's really, because there's only one implant that works, you can see that it's kind of limited with small numbers only. Here are a few examples. Follow-up is 15 months or 1 year to not even 2 years. And you can see which kind of implants have been used as well. Here's one where joint penetration with the guide wire was visualized, and here you can see the cement leakage, which is why a lot of concern has been raised. And you have to be really careful when you use the technique. This is the only prospective multi-center study that has been shown, and you can see a low surgical complication rate, no migration of the blade, and no complications related to the cement, but you can see it's only 62 fractures from 5 European hospitals. There's a systematic review that found out, okay, we need better studies in order to find out if it's working. And here are some technical aspects. The cement is ready to use. It doesn't get too hot. The new cement that you can use. You have to make sure that there's no lateral opening, and you have to make sure there's no option for leakage into the articular space of the and so people test it using contrast medium. So then this is how you do it. And then once you have the implant inside, you can see there was the testing has not been done in this case, but here you can see the cement is coming out, and it will distribute around in this area. and this is how the postoperative X-ray should look like. And here you can see how very nicely the surface of the implant is being increased. There have been some discussions about the cementation, intraarticular penetration of cement. We talked about it. Embolization is obviously an issue in hip prosthesis, but in these cases it has never been found, partially because you use very small amounts only, and you don't insert it like you jam in the hip prosthesis with a hammer, but you just do it gently. Temperature, we talked about it, it's not an issue anymore. Loosening of the cement has not really been described. And infection and hardware, I can tell you that I have removed a few of these implants. And what happens is once you start using the screw mechanism, then usually the cement breaks off. And so it just stays around this area and doesn't really move. So these are my, this is my contribution, rather specific. I was very interested in listening to all the other speakers because there's a lot of knowledge around here in this among us. Thank you very much.
Thank you. Thank you, Professor Pape. Can I have some question? Because I know you have another meeting to go on for. When you are cementing, do you have a talk with the anesthetist regarding the effect of cementation, which may happen in this kind of a situation? Because we are not putting a very hard cement, we are putting a relatively liquid cement. So do we ever consider that part as an issue?
Well, you always do it in hip fractures when you put in prosthesis. That yes. It is actually that is a standard. But here, for the proximal femur, whatever you sometimes people will talk about it, but I've never seen any complication. And so yes, we tell them we are using cement, but it's not so relevant.
Okay. So, but so in the literature also, we don't have any such a report of this cementation giving us a problem in systemic way.
No, not really. And we also use it on a regular basis for the spine. And in the spine, you can cement the screws as well, but it's this tiny little amount. And in the spine, obviously, I guess there will be another talk about it later on. But there is more of an issue in the spine just because it floats away through the veins around in that area.
Yes, thank you. Mehul, do you have any questions to Professor Pape? Because
yeah, I have, Dr. Sen. Can I ask?
Yeah, please.
Yeah, very interesting to know about the cementation. So only thing, I just have one question, like how much you inject and how much the consistency that you use for the injection of the cement?
Well, it comes in small syringes. And so you inject it through the metal. And so they give you 3 or 4 small syringes and it's, the total will be probably 1 to 1.5 cc's. So it's not a lot.
And the consistency, like what we use in the spine, also the same consistency like in the spine?
Yeah, exactly. It's exactly the same.
Like we do in the vertebroplasty, that's the same.
Exactly.
Okay. Thank you.
Mm-hmm. Mehul, do you have any questions? Yeah.
My only question is regarding pelvic fractures or sacral fractures. With these fractures, obviously there's a tendency for cement to go through the fractures and possibly affect the nerve roots. What's your experience with pelvic fractures, namely sacral fractures?
Okay, well, there's 2 things. There's on one hand, there have been some publications that use it, but if you look at the most recent studies and the more recent literature, people haven't really found any advantage. And so basically what we are doing, we are using in the sacrum, we are using 2 screws instead of 1. We go all the way across. So we, even if it's only a unilateral fracture, we do a bilateral coverage because the patient may come back with a secondary problem on the other side. So we basically cover both. The pain level improves quite a bit without using cement, and so we don't really use it.
No.
We tried it in the early days, but don't use it anymore.
Yeah, agree. We don't tend to use it either. Yeah.
So thank you, Professor Pape. I mean, I know you have another meeting to go in for, so thanks a lot.
Thank you for having me.
For joining us this evening.
Thank you.
Yeah. Mehul, now you can share your screen, please.
Yes, sure.
And just in between, let me tell Dr. Sanjay Vadada to look at the chat box for the questions which are there, probably relating to your specialty.
Great. Let me know when you're happy for me to start.
Okay.
Can you hear me okay?
Yeah.
Sure.
Great. So I'm going to spend the next 10-12 minutes talking a little bit about atypical fractures. We've heard a little bit about osteoporosis management, and now we're going to look at some of the potential problems that can occur in a small group of patients who undergo long-term osteoporosis treatment. So I work in Bristol, which is the southwest of England. I'm fortunate to work in a trauma centre. Thank you very much for the invitation to come and speak to this learned group of faculty and delegates today. I have a special thanks to Dr. Sen. Thank you very much. What I'm going to do is talk a little bit about what atypical fractures are, talk about some of the pathogenesis, talk about causality, talk about some of the controversies, explore some of the clinical relevance, and then talk about some of our local experience here. So atypical fractures really are subtrochanteric fractures. And if you look at all femoral fractures, subtrochanteric fractures make up about 3% of that group of fractures. If we look at the atypical fractures, they occur due to minimal or no trauma. They have a specific fracture configuration and pattern. So they are almost transverse or a short oblique fracture type. They have a medial spike, and I'll show you an X-ray to show what I mean, but they have a medial spike. They have lateral cortical thickening, which needs to be appreciated, and we saw that in one of the previous presentations already. They occur in the strongest part of the femur, so the forces or the mechanics required to create them needs to just be appreciated. They can present pre-fracture, so patients may complain of thigh pain, and you may x-ray them, and if you're not looking for this, you may well miss it. So it's really important to appreciate the prodromal thigh pain. And there may be preceding stress lesions as well, and again, these need to be appreciated. It was first reported in 2005, so there you go, 15 years ago, in a series of 9 patients, and these patients had been on bisphosphonate therapy for between 3 and 8 years, so an average of about 5 years. And this is classically what you see with a bisphosphonate-related atypical fracture. So some of the things we've talked about the subtrochanteric region, we've talked about this medial spike, we've talked about the transverse element of it, transverse maybe with a short oblique, and then look at the lateral cortex here. Look at that, much more thicker than the rest of the femur here. So this is abnormal, this is pathological. What's the size of the problem? Well, we've heard quite a lot of stats already today, but approximately 50% of women over 50 years of age will sustain an osteoporotic related fracture during their lifetime. And the other side of this is that 1 in 5, so 20% will die within 12 months. And these are important facts to bear in mind. If we look at this publication, 2011, for every 100 typical fractures that you treat or prevent with bisphosphonates, you will have one patient who has an atypical subtrop fracture. Okay, so you try and prevent 100 hip fractures from occurring. You will have one subtrochanteric fracture. What's the pathogenesis? Well, it all affects the osteoclast and the various pathways in osteoclast function. But the osteoclasts have been affected and they cannot resorb and heal bone. Various studies, again, all of them small numbers, small case series, but all of them show that bisphosphonates, long-term bisphosphonate therapy is associated with atypical fractures. A systematic review, so this was looking at 32 studies now with 141 atypical fractures in females who had been on bisphosphonates for about 5 to 7 years, and they showed that there was an increased risk of bisphosphonate fractures with long-term bisphosphonate use. Our experience, so we looked at our caseload over a 5-year period, and we found that our statistics were 1.1 per 1,000 patients per annum who were on bisphosphonate treatment. We looked at our series of 12 fractures. 2 healed without any problems at all. There was a 42% revision rate. So this is massive. You know, this fracture pattern does create problems. And our results of 42% revision rate are very similar to other series in the literature. This was published from our unit 2 years ago, and this just outlines a strategy, a surgical strategy for managing these complex problems. And I'm going to go through a couple of cases. So this is the patient that we're looking at. This is the cohort, the elderly patient, usually females, but it can occur in males also. And this is her X-ray. So here you see a subtrochanteric fracture. You see the classic pattern that we've talked about. It's in the subtrochanteric region. There's that transverse element with a small beak medially. There is a little bit of lateral cortical thickening, but it can't be appreciated on these X-rays because of the deformity in the proximal segment. So this patient has an intramedullary device, an intramedullary nail. They're trying to get a reduction with a cable here as well. And now you can appreciate that thickening of the lateral cortex. That bit is abnormal. It's thicker than there, and it looks like typical non-union type bone. The other thing you will appreciate is that this is inverus. Okay, it's not quite anatomically reduced. So this is what happens. A few months down the line, the nail breaks. The fracture hasn't healed because we know these fractures take longer to heal than normal, and the nail breaks. Okay, so what do we go ahead and do? We go and change the device, thinking actually, you know, it's a surgical error. It was nailed in varus, so there's a surgical error. There's a mechanical problem. Let's go and change that. Let's go and sort this out. So the patient has another device, a blade plate this time, to try and correct the varus and try and compress the fracture to try and get it to heal. What happens? The blade plate breaks. Okay, so it's not just a mechanical problem. It's more than that. Okay, what happens thereafter is the patient has an infection. So we go in, change the device once more, put in some antibiotic loaded beads, and this then goes on to heal. So it's important to think about where the problem is. Is it the patient? Is it the surgeon? Is it the implants? Or is it the drugs that the patient's on? And I will put it to you that it's all of these, okay? And so when we're thinking about this, it's important to think about the biology. Can we change the osteoclast function? We might be able to alter it to some degree. We might be able to change it in the long term if we stop the bisphosphonates, but this takes a while to occur and certainly isn't going to be very effective in the early stages of fracture healing. We can do something to the bone. We can make the bone bleed. And we know if we've operated on these fractures, when you open these fractures up, the actual fracture site is like ivory. It doesn't bleed. So we can do something to try and change that. And then we can do something about the mechanics. We can make sure that the femur is not in varus, so we can try and prevent varus. But it's important to understand when you look at these fractures, before the actual fractures have occurred, the bone is already in varus. It already has changed and has changed into varus. So if you put the fracture, or if you put the bone back to where it was pre-fracture, you will put it into varus. So you've got to do something to change that to try and get it out of varus. So this is what we propose, and this is what we're certainly doing more and more for these cases. So I tend to do a valgus subtrochanteric osteotomy. I excise the non-union from the lateral side. I put a little reduction plate, an anterolateral tension band plate, which alters the mechanics, okay, and alters the center of rotation. And then I usually use a locked intermedullary device. So this is how it looks in a schematic diagram. This is from our paper. This is what you would have if you fix the fracture with a nail. However, this is what we tend to do. So we take the wedge out from the lateral side, put a little unicortical plate, and then nail it. And we change the center of rotation, which is usually here in the middle, to the lateral side. So practically speaking, this involves, I usually do it in the lateral position, closing wedge osteotomy, a small DCP plate, and then using a trochanteric entry nail through the piriformis fossa. So this is a case, another case, a 67-year-old lady, previous scoliosis correction, pain in her right thigh for the last 3 weeks, been on steroid for polymyalgia rheumatica, and was on long-term alendronate therapy, more than 5 years. This is her x-ray when she comes in, and again, a typical bisphosphonate type fracture, short oblique type fracture, some lateral cortical thickening, and in the subtrochanteric region. So the initial management for this patient, she has a splinter fracture. We stop the alendronate and we fix the fracture. So this is her intraoperatively, and she was fixed. And you see again, if you look at that x-ray, it's still in a bit of varus, and you see that lateral cortical thickening. On the lateral, it looks pretty good, and distally, it looks pretty good. Post-op, those are the x-rays, and we see that it hasn't quite been reduced anatomically. It looks good on the lateral, doesn't quite look great on the AP. So 3 months later, again, she breaks, okay? So what do we do? So we have a problem with a non-union, we have a problem with broken metalwork, and this is what I did for her. So again, lateral position, opened up the fracture site, got the nail out, and then this is her during surgery. So a small plate on the lateral cortex there, leaving space for the nail, and then nailing it with a capillomedullary device. And that's her 3 years later. After 6 to 9 months, she was fully weight bearing without any pain at all. So in summary, bisphosphonate fractures are an increasing problem for the orthopedic surgeon. The reason why they're a problem is that they're difficult to treat. They have a high failure rate, and currently there are case series looking at recommendations of treatment, and we have outlined that in our paper as well. It's important because you might be able to pick up some of these fractures before they actually occur. So there is a prodromal phase, and someone who comes in with thigh pain should potentially be investigated, and you should have a high index of suspicion, certainly if they've been on bisphosphonates for a long period of time. If this fracture has occurred, you do need to stop the bisphosphonate for a period of time. And when you're thinking about surgical management of these patients, think about optimizing the biology, optimizing the mechanics, and as we've heard importantly throughout all the talks, think about the biochemistry as well and try and rectify all of that. Thank you.
Thank you, Mehul. Just some more questions before we really proceed further. If you are okay biologically and mechanically in these situations, because the cases which you pointed out, there was something going mechanically also, we can say in the first go. If both the things are okay, still are we likely to have a problem in the Heulian in these cases?
Yes, absolutely. So we've found, if we looked at we've done an extensive literature search, and even if getting your biomechanics right and getting your biology right increases your chance of successful union. But even if they are right, these fractures have a higher failure rate than standard subtrochanteric fractures. Absolutely right.
And then I want a question from Dr. Sanjay. In this situation, the fractures which are caused by bisphosphonates now, what could be the endocrinological management for such a fracture?
Yeah, that's a very good question. We've talked about teriparatide and maybe using that for a period of time, maybe using that to try and treat these patients or encourage healing. But again, we don't have any clinical RCTs. We don't have any studies which are in a randomized control environment to show whether they make a true difference or not. So I think hopefully we may have some answers in the next few years once we know a little bit more. But certainly there's no level 1 evidence to support that.
Yeah, Mehul, just a question, whether her scoliosis was operated before or it wasn't?
Her scoliosis, she did. Yes, she did. She had an operation. She had a limited correction. Okay. Absolutely.
All right.
So, Dr. Sanjay, any input into this situation when we have a bisphosphonate-related fracture?
Right. So, as Dr. Acharya was telling that there is no RCTs, but there is some evidence is there that with the bisphosphonates therapy, there is osteocytes are decreased in number in the bone tissue when the biopsy was done in these patients.
Yeah.
So we can plan some treatment to improve the osteocyte activity, and the teriparatide is one of them that can be used. And of course, I agree to Dr. Acharya that there is no well-designed randomized control trial, but we have a small experience. A few patients, these are having the SSBT and treated with the teriparatide, but interestingly, few patients responded very well within 6 months to 1 year. But 1 or 2 patients out of a series of 20 did not respond even to the teriparatide for the 2 years. So that is one of the issue.
Yeah, yeah. What we've done is we've tried to set up a regional and then taking that forward, a national database of these atypical fractures. And once we know how many occur, we're thinking of trying to see if there is a way of setting up a randomized trial. We'll see.
Yeah. So actually, if you remember, if you've seen the atypical femoral fracture, the very first report is reported by Dr. Rao and Odwina from Henry Ford Hospital.
Correct.
And they are one of the person that first reported that this kind of abnormal fractures are there. And their institute, they are working on this NHS trial, the ongoing study, and they're analyzing the bone biopsies from the patients of the SSBT, and they reported that this osteocyte number is reduced significantly. So that may be a possible cause for that fractures.
So the question comes, can we anticipate it and do some tests which can tell us about the happening of this kind of a situation?
Well, you can do the bone markers, and that will give you some idea, but that is not 100%. So that is in addition to the bone mineral density, you can do the bone markers that will give you some idea, and that will help you to decide to continue with the bisphosphonate or to stop the bisphosphonates.
Okay. Professor Pepe, do you want to add something from your experience in Switzerland?
Well, I thought that this is a very interesting talk. Congratulations. The question that I have is, when you had the idea to add the plate, you decide not to remove it after you got the perfect reduction. And do you think it is helpful to get direct bone healing? You know, like in the good old times?
Yeah, great question. So so what I've done is I've put the plate on, and then I as you get confused because what type of bone healing do you want? Do you want primary bone healing, or do you want secondary bone healing? So, and this is a bit of a hybrid fixation, but you're quite right. So I've taken the plate off, and sometimes what happens in the osteoporotic bone where you've got a capacious metaphyseal region, you do get some secondary displacement by taking the plate off. So that's why I leave the plate on. What are you trying to achieve? And I think rather than trying to achieve either primary or secondary bone healing, what I'm trying to do is to change the center of rotation of that whole configuration. And my lateral or anterolateral tension band plate will help with the reduction. And I think it'll change the center of rotation of the mechanics in that femur. So that's what I'm trying to achieve. For me, it doesn't matter whether it heals by primary or secondary intention. What I want to do is get the bone surfaces together. That's and mechanically aligned.
Well, I mean, I think it's interesting because the same principle works if you have a shaft non-union. Sometimes you're just adding, you leave the nail inside, and adding the plate will help. Or you can do it in very proximal fractures where you have a nail and a plate. So yeah, there must be something helpful. Exactly.
Yeah, absolutely.
Yeah, it's likely to be a good challenge for the days to come, and because bisphosphonate therapy being so common, we are likely to have all these situations coming. So now we can go to Dr. Shailesh because he has been waiting to talk. So
yeah,
we will be talking about spine fractures. Please, Dr. Shailesh.
Yeah, I'm just sharing my screen. Is it there?
Yeah, quite.
Yes.
Yeah, good evening, everyone. I must congratulate all the speakers and Dr. Sain for an excellent show so far. And we are in the last talk about spine and osteoporosis. A lot of things been said and talked about osteoporosis and spine, but when it comes to something which is very commonly seen nowadays in orthopedic neurosurgery and spine surgery practice, this is when the patient comes to you like this. And we see that there is a thoracolumbar kyphosis, there is a fracture, severe pain. So things which we should keep it in our mind. I will go mainly case-based because a lot of things which already been talked about by previous speakers. Whenever the patient comes, we always think about how can I treat this patient non-surgically. This will be my first option because patient doesn't want either the surgeon. Whether we can treat it with non-surgical management, medications, bracing, treatment, medical, all these things. If the patient is with bad pain and not been able to get better, then the next option can be cement augmentation, what Dr. Pepin has also spoken about. And the last option is the surgical option. And these are the three main options when we talk about osteoporotic fracture. Which all basic investigations we think we do when the patient like this comes. We always think about doing a basic bloods because sometimes it can be a myeloma, no fall and still a fracture. We always think about hypercalcemia, anemia, raised alkaline phosphatase, basic parameters, Ben Jones proteins, and then it differentiates it from a routine fracture. So basic blood is very, very important when we do a basic X-ray and blood parameters. Then we talk about doing an MRI and DEXA scan. What is the important and rational? If the patient is persistently not better, then we always check about instability, worsening neurology. These are the surgical indications for any patient. If there is a retropulsion, we will not think about vertebroplasty. We will have to think about a surgical option. And these are the also progressive deformity. These are the cases where we will have to think about a surgical option because there is a kyphosis and the patient is in terrible pain, not getting better, completely vertebra plana. And these are the simple tips which we all should know is most important is level. We should never miss a level because we have exactly a right level we should aim at. In osteoporosis, bones are very weak. In general principle, we always consider a longer stabilization in deformity because there are chances of back out. We always use a different type of screws. We will come there. And important is a very good exposure. We should expose very well because we have only one pedicle. If you lose the pedicle, you will be in trouble. So always confirm it in image intensifier, and that's the most important thing. If you see the image intensifier image here, we can see through the bones. There's so severe osteoporosis, and that is always a challenge. And these are the special screws which we are using now, augmented screws and things like that, and we really can get. This is the 1 year follow-up, and this lady is doing fine. And despite of telling her that you should not use the belt, she wanted to use the belt. And when there is a choice, we will never force the patient. But in general, these are the scenarios. If you see this X-ray and we see, oh, there is a fracture, we see a fluid sign, and this is definitely compressing. So this is where we have to think about whether I should consider a vertebroplasty or should I go with stabilization. And I will not go into the detail about this, because vertebroplasty we always consider as one of the best modalities for treating the fractures. And we personally prefer vertebroplasty when there is not much of a retropulsion, not much of angulation, not neurological deficit. These are the three important things, and not significant collapse. These 3-4 things are very important when we consider a surgical management without doing only vertebroplasty. And I will go for mainly a surgical management, as which all are the patients for absolute surgical indications. Different indications, when the patient is with failed conservative treatment, he is not been able to get better. There are various options, and this is our patient, which we are published long back, with a 23-year-old, 24-year-old lady with post-pregnancy severe spinal osteoporosis with multi-level, 5-level fractures. So these are the challenging cases which we can definitely treat without surgical options also. And it is very, very important case selection. So this is where we are coming from, and we will be moving on to the different pathologies in spinal instabilities. 78-year-old female, fall at home 2 months back, severe pain, not been able to get better, persistently turning in bed, T-score was -3. If you see, this is the double level fracture, persistent pain, and the option is very, very clear here. We have to consider, because of the double level collapse, there are very high chances the minute she starts sitting with the buckling collapse and kyphosis, we consider cement instrumented fusion in this kind of cases. Again, 68-year-old female, T-score 3.2, fall at home, hip and spine fracture. It's always a dilemma whether we should fix the spine first or the hip first. And we have a team, we have a very good hip unit. We always discuss with the colleagues, and because at a lot of time there needs some kind of a mobilization for the hip fracture reduction, we prefer to do the spine stabilization first and then consider the hip. And this is where we have done there was a retropulsion, we considered stability, and we use the corticocancellous dual core screws, fix the spine. We can see it very nicely opened up, fracture, the deformity is corrected, and the hip also was fixed and she was mobilized. Different scenarios, 65-year-old female operated 5 years back for a severe stenosis and multi-level instability, comes to us with again a fall, DEXA T-score is -3. And again, there is a fracture, not getting better with medical management, severely disabling pain. And then this is the case where we need to augment it higher above, and because it's going to create more trouble. So we have to go till the stable zone in this kind of adjacent segment diseases, and sometimes we can get away with vertebroplasty, but where there is a instability, borderline chances of a junctional level thoracolumbar junction, we will prefer to stabilize these patients. Again, interesting cases like CA cervix with METs comes with back pain, difficulty to stand, and then worsening neurology. And when we see the X-ray and MR, there is a complete collapse and a cord compression. There is no option. We need to investigate everything in detail, and we need to stabilize, decompress the spine, because remaining modalities will definitely of a little no value. And this is where we decompress the spine and send the material. It comes out as osteoporotic material. Not all the tumors will post radiation will post chemotherapy will come positive for the metastasis. We did an anterior reconstruction, and the patient is so far doing well. This is nearly a year now from the time we operated this lady. Different scenarios, 79-year-old lady fall at home and severely disabled, tried all the possible medications, not better. And when everything was exhausted, they wanted that we want to make her stand and walk. We can't just take it. She couldn't sit either. Even sitting was very painful. And after giving adequate treatment, we thought of giving her a complete stability. And this is a dual threaded screws which we normally use, which are very useful. We'll not go into the video. And this is the hydroxyapatite crystals which we use. Sometimes we use the DBM, demineralized bone matrix, also to stabilize the spine, and she is mobile now. We'll not go into again the details as the time constraints, but we will talk about few cases, the interesting ones. And this is a patient with surgery for the lumbar issues 3 years back elsewhere, and he comes to us with persistently poking implant in the back, neuro intact, and his T score was 2.9. Again, a challenge. We have to plan for a stabilization, as we need to remove that implant which is backed out and fix above and below to give a stable spine. And we have used this demineralized bone matrix. It's a bit costly, but it's really useful in such situations. And he's a CEO of a company, very demanding, and luckily he's doing very fine so far. And this is where we rescued this patient with this kind of a stabilization. Again, with kyphosis, as we talked about, these are the cases where we have to think whether if you do a short segment fixation in this, there are chances of implant failure or chance of resurgery. Therefore, it's better and safer to do a longer constructs in this, and really you can get better outcomes. This is our experience. And as we go ahead, there are various different things which have come in this time, where we are using the cement augmented screws. Lamina is one of the stronger construct where we can use the sublaminar wires as well in fewer cases. Again, a 72-year-old patient comes to us with back and leg pain, weakness in the hip, and this is where the fractures were. And there is, again, it has to be decompressed and stabilized, and we have used some kind of implantation where we use this segment augmented screws and stabilization. Again, we used to use sublaminar wire. Still we use in fewer cases of osteoporosis, because lamina is a very good construct, and this we can really treat very well. Sublaminar wire and hard shield rectangle. Expandable screws have come in market, and they're also having a very good pull-out strength. I will talk about one very interesting case, a 49-year-old man with severe pain for 2 years. And these were his snaps, couldn't walk much, sitting was a problem. He was operated for adrenal tumor, and he had all the possible things like type 2 diabetes, on insulin, hypertension, and was not a good candidate. And he had a multi-level fracture, and he was treated with a vertebroplasty previously by the previous surgeon, and they had done a very good job, but still the persistent kyphosis was progressive, and he started complaining more and more. When he came to us, there was no option but to correct this sagittal balance, which probably would have given him the best possible outcome. As he was really frustrated, he was having suicidal tendencies, and we thought of taking all the possible opinions. We took endocrinologists and physicians, everyone's opinions were taken, and we planned for stabilization, where we studied the pedicle screws, how we should plan, and and we have sent a paper for publication, how to use a pedicle screw in previously augmented vertebral bodies. And all these are very challenging, where we involve all the team, and we planned for appropriate, we marked all the levels, and we planned for multi-level construct from top to bottom, almost D4 to S2, because if you stop in between, there are very high chance of again fracture, as this was a 5 to 6 level fracture, thoracolumbar, and we were lucky to get a complete kyphosis correction and a good fixation, sacropelvic fixation, and this patient did really well. So far, he's managing, and he's again under treatment with the endocrinologist for his medical issues. So these are the challenging scenarios in spine surgery, where there is one simple thing, is that one is the patient comes to us with no history of trauma, and the second, the patient comes to us with a history of trauma. The patient who is not coming with a history of trauma, there are chances of having some kind of any other issue like myeloma or any metastasis are definitely there. So we need to be very vigilant, careful when we think about planning for any option for this. Most importantly, the detailed assessment and evaluation of these patients, and we have a very good chance of getting good outcomes with latest advanced techniques these days. Thank you for your
Thank you, Shailesh. Just before we go further, I want to have a small question. You said about, we know about the when you are putting a cement in the vertebrae for a vertebroplasty or anything augmentation. You
Yes.
talked about DBM also. And I remember, I am not very sure about from the US literature, there was some problem of using demineralized matrix around the in the vertebrae, especially in the cervical spine, that they may augment a newborn formation and which may have a neurological deficit. So anything
Yes,
like that?
yeah, means BMP and DBM, two things, BMP. BMP had some issues, yeah, and DBM is nowadays it is becoming quite useful, and we are very careful. We are not using it very close to the cord. When it is completely away from the cord, because there can be chances of addition, means extra fusion, extra bone formation. So yes, definitely it is yet under a lot of research, but DBM is reasonably safer, sir.
Okay.
Yeah.
So, Neeraj, what time do we have right now? I put deliberately Shailesh over there so that we can get extra time. So, Neeraj, what time do we have now? So, till the time we are on, we can keep on going on. So we have a lot of questions to talk about. Among the faculty, is there any specific question to any specific person we can have?
I have one question from Dr. Salis. Can I ask?
Yes.
Dr. Salis, fantastic, very, very interesting cases. You have done wonderful job in the spine. So only thing I just want to know, like, does it matter for you, like if patients is suspected of metastasis collapse versus the osteoporotic collapse? Because you are the fixation device, like all the cases, your fixation was not on the, like, whether the etiology is the osteoporotic or the metastatic or the other thing. Did you consider the etiology factor also, and if it's there, then how you evaluate those cases?
No, it's very important, as I said in this last case, where we always think about what is the reason for this. Number one, so always etiology based. Is it a simple standard osteoporosis, DEXA scan, rest all things are not there, or this is having something, primary reason. So we have to always tackle the primary reason as best as we can. In the same time, very few of them will need surgical intervention. Most of them will settle well with medical management. That is our experience. Only those who are worsening with neurology or with significant instability pain, associated deformation, which is progressive, only these cases we have to be more thoughtful to plan for any surgical intervention. Otherwise, medical is the treatment first, it's our unit's protocol.
Okay, thank you.
What medical treatment you use for these fractures?
As standard, we always start with bisphosphonates, but as per the DEXAs, we prefer teriparatide in spinal fractures in most of the patients. And these days we have started using denosumab in last 1.5 years.
So very interesting. How frequent you see the celiac disease?
Sorry?
Celiac disease as a cause of osteoporosis?
Yes. We would like you to enlighten about.
No, I'm just asking because you have a lot of high volume patients. And just seeing, I'm just looking what are the secondary causes you are ruling out before fixing and all this.
But we have very good team like you, where there are endocrinologists and guys who are treating, and we always take their.
That's good. Yeah. That's
for a good question, Dr. Pape, you are still there. Can we have your presentation of that kind? You said the geriatric fracture management as such. Can have
well,
that
I was going to ask one question because the last case, it was really a challenge. And so my question to you would also be a technical one. How can you avoid pull out of the screws when you insert them? Because according to your measurements with the cement in place, you had to use shorter screws, right?
Yeah. No, so if you see, this was a very challenging one. If is the screen on? Is it there? Screen?
No, you will have to share it.
Okay, I will.
You showed the CT slices where
Yeah, I'll share my screen. I'll just
cement
put
was
the
in the
last
front.
slide. Is it there now?
Yes,
Yes.
yes.
So you, because you went above and below.
Yeah. So what we did was, a very good question, Professor. In this, what we thought, we should take this cement as an advantage for us, because cement will give us better hold. What we always talk about is, cement augmented. So it's already augmented 3 years back. So how we can do? So we thought of drilling those vertebral bodies, and we checked the right and left side pedicle where we can go in longer length in all these 5-6 levels. And that is how we planned, if the vertebral, you can go like a drilling inside the cement and then tapping over it, and then the hold was amazing. And it's like a deformity correction, and you stabilize your apex and you get a very good outcome. And remaining where the bone augmented screws, therefore we were lucky to get this longer construct completely. And this is how, if this is the side where I can put my screw, this is where I should try to put. And so if I need, I can use a tap to increase my screw length. And this is what we planned. And luckily, if you see, we could get in almost 4 levels where the cement was fixed. And that probably gave us the better stability.
Thank you. Now, Professor Pape, do you want to share your idea about geriatric fracture management?
Well, I think it's pretty global. So my personal idea is pretty much the same as we've seen it here. And so in our unit, we have a low threshold for putting in cement. What we have recently performed is, in these cases, the spine jack. It's a device you insert it into the vertebra, and then you can expand it while you're inside. And it works like a jack, the one that you use for a car. And we have seen quite good results using that technique. But it's also, I think, the cement is universal.
Yeah.
Yes, thank you. There is a question on the YouTube. They say, I think Dr. Mahesh has already shown in one of the slides also, but how do you differentiate between osteoporotic collapse and metastatic collapse? Dr. Mahesh, please. You have to unmute and then say. Dr. Mahesh, are you there?
Yes, I am there. Should I show the same slide again?
No, if you can speak, it's okay.
Yeah, okay. So actually we have to rely on the signal intensity of the vertebra. So like in the osteoporotic collapse, usually the signal intensity either hypointense on T1 as well as T2. With the metastatic collapse, usually there is a posterior bulge. Then there can be associated soft tissue component in the metastatic collapse. Or in the osteoporotic collapse, we don't expect any soft tissue, paravertebral soft tissue. And if the posterior elements are involved, then it's more likely of the metastatic collapse. And usually in the osteoporotic collapse, we don't see it. So these are 3-4 findings which we can differentiate most of the time, but it's not 100%. These are the relative points which we can we can able to differentiate.
I can add few points.
Please.
So osteoporotic fractures are always anterior wedging fracture. And if I can see I recall the Dr. Mahesh slides also, that MRI is typically showing the complete involvement and more involvement of the posterior part of the vertebra as compared to the anterior. Number 2, osteoporosis is a systemic disease, generalized disease. So you are likely to see more number of vertebra involvement as compared to the metastasis. That is another 2 points can be actually useful. Maybe even without MRI, that can be
Yeah,
another
even
might
the
be able.
metastasis, sir, the metastasis also can be because of multiple vertebra can be involved in the metastasis,
Yeah,
as well as in the
but
osteoporosis.
yeah, totally agree. But that is not a kind of generalized picture
Yes,
as
yes,
compared to the
yes, yes, yes,
osteoporosis.
sure, sure. Definitely, but these are the signal intensity pattern because the metastasis usually like we have some deposits and the signal intensity of that particular because it's a infiltrative disorder. The metastasis is usually infiltrative disorder, so we usually see some signal intensity which is abnormal. Usually, the osteoporotic we don't see those signal intensity apart from the involvement of the element and the soft tissue component. Usually, metastatic have a some minimal to the some component of the soft tissue adjacent to it because
Yeah.
it erode the vertebra, it can destroy the vertebra, and then the paravertebral soft tissue can be seen.
Yeah, as we are going, but that's just one question before wrapping it up. Once you operate on an osteoporotic fracture femur or vertebrae, you start with anti-osteoporosis treatment immediately. Would you like to give IV bisphosphonates or IV post-op or wait if atypical fracture is ruled out?
Question for me.
Surely, sir.
So, Salish. Okay.
Yes.
A fracture femur or a vertebral fracture, you can take it either way.
No, I normally prefer to start it at 2 to 3 weeks from the surgery for various reasons. I always feel that when we start immediately, because sometimes we have to supplement it with calcium and immediate. There are two theories, calcium. The minute we give some calcium, there are chance of constipation. And then again, the patient is having a problem. Once they are mobilized better, then we can definitely go ahead. That is what I generally feel. Therefore, I started at 2 to 3 weeks from the surgery.
Thank you. So I think because we have already overshot a time a lot. So with this, I want to thank all the faculty members to have given their best in this kind of a situation. I am definitely thankful to my overseas faculties, Professor Pape and Mehul. I'm really glad that you could spare your daytime to our evening time also. And thanks to my Indian faculty, Dr. Girija, Dr. Shailesh, Dr. I'm not Shashank is not here, and thanks a lot, Neeraj, for taking us up all through up to this point also. And I really want to thank the Crossland teams also to have given this opportunity. Thanks a lot, and thanks all
Sir,
the participants.
before we end this meeting, so there are a few questions which I have asked on chat. So I cannot copy the chat and send it to the people who are viewing. So I would just request to just read out the answers who has typed from HP. Who's HP?
Yeah, HP is Dr. Sanjay.
Yeah, Dr. Sanjay, can you just read out the answers?
Yeah.
It is the question is first is the which bisphosphonate is preferred, or start from above.
Yes, I'll do one thing. I'll ask the questions. You can answer them.
Yes.
Yeah.
Yeah. So before starting teriparatide, if your alkaline phosphatase level is high and vitamin D is very low, can we give injection arachital 6 lakh units and start teriparatide right away, or wait for a few weeks before vitamin D and alkaline phosphatase normalize?
So the thing is that we want alkaline phosphatase should be normal. So if it is high, first rule out any other cause than the vitamin D deficiency. If you feel that is because of vitamin D deficiency, in that case, you start the oral vitamin D 60,000 per day for 10 days, and that will be approximately 6 lakh units. And that will normalize your vitamin D if the alkaline phosphatase is low because of that. And instead of giving injectable, oral is preferred because oral acts faster as compared to the injectable. It rises the serum level of vitamin D rapidly as compared to the injectable.
So the choice of bisphosphonates in spinal and femur fractures.
So in spinal fracture, we prefer the teriparatide. In the femur fracture, we prefer the bisphosphonates. Now, if the patient is having the femur fracture, is preferred is the bisphosphonate. If the spine fracture, preferred is the teriparatide.
Okay. Shailesh, basically you had a different view regarding this. So the question to you was, if you are operating on a patient who's osteoporotic And Dr. Ramesh Singh, the question to you is also the same. So if you're operating on a patient who's already osteoporotic, when will you start? On which day post-operative? Day 3, day 5, suture removal. When will you start your anti-osteoporotic treatment? That is either a teriparatide or a denosumab or a zoledronic acid. And what will be your agent of choice?
We usually, as a practice, we work up on the patient before starting teriparatide, as Sanjay has already set up, and probably around 10th, because all these things are not likely to be immediately effective. It will take time. So 5-7 days working upon the patient is not a very difficult issue. So whenever possible, once after about a week or 10 days, we start mostly teriparatide as a therapy, because this is something which can be given. And we have seen, I don't know, we have not done proper studies for that, but we have seen our fracture cases to be doing much better after this teriparatide therapy. And we continue it minimum for 3 weeks to though, then we can change with something like denosumab. But we started that time as far as that question is concerned.
Yeah, Neeraj, I already answered this question that we normally start at 2 to 3 weeks, because we are along with our choice is always teriparatide as a first choice, and along with that we have to give some kind of calcium also. And if you start calcium post spine surgery, chances of constipation are there. Therefore, we prefer to mobilize the patient. Once the patient is comfortable, then we start teriparatide. At around 2 weeks is by generally we start.
So, what according to according to the endocrinologist, he is saying that the drug of choice is zoledronic acid.
This is probably when he's comparing the bisphosphonates per se.
Well,
yeah.
well,
But basically, what we orthopedic surgeons have the habit of doing is that we don't want to give bisphosphonates, we want to give teriparatide.
Yes.
But now the trend is again basically Dr. Manoj Chadda from Mumbai always says that now he is shifting to zoledronic acid. In fact, he says that you should give the zoledronic acid before you discharge the patient.
Okay.
So how do you agree with it as an endocrinologist?
They might give, or Mehul, do you have anything opinion about that?
well, the concept behind that is that the discussion was going on because this kind of thing happens. The patient, you are not sure the patient will follow up you with or not. In case patient is, you are sure that patient will come to you, you can wait for 7-10 days. But this concept is in the government hospitals where they are not sure that patient will come back to you or not.
Okay.
So at least you start some treatment, and some treatment basically it is the studies are better that hip fracture, the bisphosphonate is zoledronate is preferred, or the spine fracture. But for the early healing, you can use teriparatide for few months.
Yeah.
So there is one more question which is basically have been going on amongst our orthopedic surgeons. So patient is osteoporotic, came with a fragility fracture, we operated, gave teriparatide for few months. Now in a lifetime, we can only give it for 24 months. So
Yes.
if we give it for say maybe 3 months or 6 months now, so can we give the rest of the 18 months later on?
Yes, you can give. Yes,
But
I'll say,
yeah.
But I'll say you can give at least 1 year if the patient is ready to take, because the issue is that daily injection is the problem. So if patient is affording and can take, better to continue for 1 year, then you can switch to the bisphosphonate or denosumab. Then you can use 1 year later also. And that's why I given the choice of weekly teriparatide, the 60 microgram. So you can use it for 5 years rather than just using for the 2 years.
Okay. Incidentally, when we tell to our trauma patients to give it for a year, they are little reluctant to have some.
Yeah, definitely. Yes.
For 1 year. So we tell them 3 months. By the time of 3 months, their fractures are reasonably okay. They are mobile also. They feel happy also. And their positivity for this injection also increases a lot. But then we do give a choice, as we have been discussing in our own meetings also with Dr. Sanjay Vrada, is advised that we can shift over to denosumab after 3 months period of teriparatide, so that eventually after 6 months again we get a 3 months course of teriparatide, and that way the efficacy can go in for 3 years, 4 years, 5 years by the time we complete 2 years of the teriparatide. Yes. I don't know, I mean, it is how logical or how it will settle down, but that's one perspective.
Okay, I think this is time for today. We had a very nice discussion on osteoporosis. So I would like to close the meeting. And we would also like to thank our sponsor, Sun Pharma, for getting on with this meeting. They are the makers of Bonista, one of the teriparatide molecules. And we thank all the speakers to be online for an extra 1 hour. Thank you very much from Ortho TV, and good night and good evening to everyone.
Thank you. Thank you so much.
Thank you.
Thanks for
Thank you,
the
Dr. Girija. Thank you. Thanks, Dr. Mehul.
Bye.